Today we're going to talk about GI disorders in pediatrics, and these are the same in many ways as they are in adults, but also different. We'll cover diarrhea, constipation, lactose intolerance, GERD, and inflammatory bowel disease. I'm going to kind of run us through the etiology, the disease process, and then the nutritional management of these disorders. So first of all, we're going to talk about diarrhea in pediatric patients. And just a brief definition of diarrhea can be passage of 3 or more loose, watery stools per day, or a more precise definition if you have greater than or equal to 10 mils per kilo of liquid stool daily. So in particular, if we're talking about children maybe who have short bowel syndrome, you're really going to want to quantify how much stool output they have, because they may have chronic passage of liquid stools, but as long as that stool output was within a certain range, we consider them to be well controlled. So traditionally, what people thought was if you had diarrhea, you should have gut rest. In other words, just don't put anything in the gut and maybe stuff won't come out. But the consequences of this approach, if we think about it, can be that we don't get fluids in, we don't get nutrition in, and if the diarrhea is prolonged, that could actually lead to dehydration or malnutrition. So current thought about diet therapy for diarrhea is that we need to initiate oral rehydration therapy because we have fluids and electrolytes being lost in the stools. And the recommended oral rehydrating solutions are Pedialyte and the World Health Organization's oral rehydration solution. That's the ORS. So on page 280 in your book, there's actually a specific rehydration regimen that can be used if the patient's really not able to self-consume what they need. The other approach, an important approach of diarrhea therapy beyond oral rehydration, which is really essential because one of the main causes of death in children who have diarrhea is dehydration. So we also need to initiate age-appropriate feeding. So for infants, that means if they're fed breast milk or they're fed full-strength formula, then we continue to encourage the parents to feed them, to nurse them, or to feed them their formula and not to dilute the formula. And for children, really the diet is tolerated. So in a pediatric setting, and I don't know that we've talked about this, but hospital diets might be toddler diet, or it might be preschooler diet, or just a general regular diet, because the amount of food that you're going to put on the tray and the type of foods that you include will vary from their very young children, where you might provide baby foods, to your toddlers who are eating table foods, who might get, we used to, at Cook's, we had these little potatoes that were kind of baked, that were cut in the shape of smiley faces, so they were potato smiles. You might get a dirt bucket for dessert, some chocolate pudding with a little bit of crushed Oreos on top, whereas your teenager is more likely to be offered, you know, maybe a hamburger with potato chips, which would be more of a choking hazard for the younger child and wouldn't be permitted on the tray. But beyond the example of the hamburger, for children it would be what they think they can handle, they can eat. We don't want to give them sodas or juices or high osmolality drinks like you know, straight Gatorade, not G2, would be too concentrated, and it might actually provide osmotic diarrhea. We can give them lactose when they have diarrhea unless their stool output increases. So if they're temporarily, let's say, lactose intolerant because of the diarrhea, we wouldn't want to make the diarrhea worse because we don't want to have to replace more than we have to. And the same goes for diet. If there's something that a child eats, like for example, a really high fat food, might cause worsening diarrhea, and we wouldn't necessarily want to offer that. But if the child felt strongly they could tolerate it, you could try it. If it made it worse, you wouldn't want to continue with that really high-fat food. The same would probably go for a spicy food. So we wouldn't just naturally offer the child with diarrhea stimulants, and a really highly spicy food might be considered a stimulant, but if they felt they could tolerate it and stool output weren't worsened, they could have it. We also know now that pre and probiotics can be helpful for diarrhea. So prebiotics, remember, are the non-digestible compounds which then provide food for gut bacteria, whereas probiotics are the actual live active bacteria that can be provided in food. So the main prebiotics that we see are the FOSs, which are the fructooligosaccharides, and then the galactooligosaccharides, which you can imagine come from milk sources. Often these are added to infant formulas, so I put a little example up at the front of the Good Start Gentle, which we said is also, I think, a kind of a low lactose formula, also contains this product which Gerber calls Early Shield, which contains probiotics, and the Nutramigen and Flora GG also contains probiotics. As I mentioned in the infant formula lecture, I believe almost all of the Enfamil products, except for the soy formula, now contain actual prebiotics and even probiotics, and I believe the Ross products, the Similac products, contain prebiotics but no probiotics. Strains that have been used in research and have been associated with reduction in diarrhea are Bifidobacterium lactis, Streptococcus thermophilus, Lactobacillus reuteri, Lactobacillus lactis, Lactobacillus rhamnosus, GG. And so those are all strains that are have been found to be associated with reduction in diarrhea. And, you know, not all of the studies are strong, but I think the most recent analysis I saw of the issue was that basically diarrhea may be beneficial in helping with diarrhea in children. And so Culturelle Kids is a product which is a capsule that's on the market that contains live active bacteria, and I believe it's the LGG, which has been pretty widely tested. It also might be beneficial for kids who have, for example, IBS symptoms where they have alternating diarrhea and constipation. So chronic diarrhea is diarrhea of a presumed, acute diarrhea or chronic diarrhea would be diarrhea of a presumed infectious etiology that begins acutely but lasts more than 14 days. So let's say a patient has had salmonella and they have known salmonella, and so they have diarrhea relating to that, but then it becomes prolonged. Or passage of greater than or equal to 3 watery stools per day for greater than 2 weeks in a child who fails to gain or who loses weight. Possible triggers, as I mentioned, you could have an enteric infection. It could be HIV/AIDS, which creates this chronic diarrhea, or it could be some type of chronic illness. For example, we will have Tracy Winder will give us a webinar on short bowel syndrome, and those patients often have chronic diarrhea. Types, I think these were mentioned in your chronic care class, but basically you have exudative or inflammatory diarrhea, and those are basically those that are associated with mucosal damage. So the actual mucosa of the intestine is damaged, and you get this outpouring of mucus and blood and fluid and proteins. And that type of exudative or inflammatory diarrhea is basically caused by inflammatory bowel disease, IBD, so Crohn's and ulcerative colitis, and then also celiac disease can cause that type of diarrhea. Remember, celiac disease can also be silent, though, with no GI symptoms. In osmotic diarrhea, you have poorly absorbed components within the lumen of the bowel, some which might be hyperosmolar. And so because they're hyperosmolar, through osmosis causes the movement of fluid rapidly into the lumen to decrease that osmolarity, and in so doing, it draws the contents of the intestines quickly through the gut. And so lactose intolerance, which we know is pretty common, especially in people of color, and fructose intolerance, which is probably less well recognized but is also more common than previously thought, those can both cause osmotic diarrhea. Secretory diarrhea is caused by active intestinal secretion of electrolytes and water. So that's not just something, it's not caused by something being in the lumen that then causes water to rush in and pass through. Instead, it's the intestinal cells are secreting water and electrolytes. So bacterial endotoxins and viruses can cause this type of reaction, and secretory diarrhea is not going to be alleviated by fasting. So if you've ever had a patient on TPN and they have diarrhea and nobody seems to understand it, that would be more of a secretory type of diarrhea, which is caused by typically an infectious cause. And then dysmotility can cause rapid transit. Irritable bowel syndrome can cause rapid transit, and that basically means the normal motility of the intestine is disrupted, and so food contents pass through more quickly. And we don't exactly know the causes of that dysmotility in some cases. You can also have medication-induced diarrhea, basically antibiotics, which reduce your good bacteria, which then cause contents to move through quickly, or you might have other medications that actually have more of an osmotic type effect. Risk factors for the chronic: children aged less than 6 months are more at risk, and part of that probably has to do with their sort of immature immune system and immature gut. So they aren't maybe yet fully colonized and used to their own bifidobacteria, don't have well-established lines of bifidobacteria to fight off infection. And then if you're not breastfed, if you're on formula, you might be more prone to those effects because you don't have bifidobacteria consistently coming in. If they've had an acute diarrheal episode within the past 2 months, that's also a risk factor. Sometimes the disruption of what happens in the gut is started by some sort of infectious cause, but then persists because you don't have reestablishment of normal bifidobacteria. Zinc deficiency is also associated with chronic or persistent diarrhea. Lack of breastfeeding, as I said, was a risk factor. Male sex seems to be more associated with chronic diarrhea, and also history of intrauterine growth retardation. And that may simply indicate that there weren't maybe enough nutrients on board to have all parts of the body functioning well when you're born. So maybe the gut isn't fully functional. Okay, constipation is defined as delay or difficulty in defecation, which is present for 2 or more weeks and is sufficient to cause stress to the patient. So this, it's not so much that you have to go a certain number of times a day or per week. It's that delay causes stress to the patient. Some people may typically go every other day and they feel no intestinal distress and they don't have trouble going when they do, and so that's not constipation. But when they can't go and it causes distress, that's constipation. The treatment in infants, first thing is verifying that they're mixing formula correctly. When we talked about formula mixing, remember the typical concentration to get to a 20 calorie per ounce, or in the case of Similac 19, is 1 scoop of powder per 2 ounces of water. But as I showed you, when you scoop up the powder, if you're not mixing that very carefully, and maybe you do a really large scoop, you could have a concentrated formula. And if the child then doesn't eat that formula that well, they won't get the amount of free water that they need in order to have normal passage of stools. So the typical treatment, you're going to make sure that you increase fluid intake. So is the child taking what's called full feeds, which we remember was about 150 to 170 mils per kilo, but a child can safely take up to 200 or sometimes slightly more mils per kilo. And then juices with sorbitol can also be used. So apple, pear, and prune, so those same things that we might avoid on a FODMAP diet. Sorbitol is kind of a something that causes motility to be increased, and so if you provide maybe 1 or 2 ounces of pear juice or prune juice, you might be able to get the stools to pass through more quickly. In children, you can work on increasing fluid intake. This is a common cause of lack of motility in children, is they just don't like to drink. They won't drink unless they're feeling a strong thirst impulse and they don't recognize a slighter thirst impulse. Also fiber. So the adequate intake is 14 grams per 1,000 calories, just like it is for adults, but there aren't really good studies to establish what level of fiber children need. People used to use the rule of age plus 5, and you can imagine, so for an 8-year-old, that's just 13 grams a day. whereas an 8-year-old might consume almost 2,000 calories a day, which is 28. So there's a big differential between the rule of thumb for fiber intake and adequate intake. But I can tell you that a huge number of children don't meet adequate intake, and there is controversy within the field about whether that intake level was too high for kids, whether they'll be able to absorb all their nutrients at that high level. Also getting them to increase their activity. If they're very sedentary or if they have a disorder which actually limits activity, then they may need to increase their activity to help alleviate constipation. Encopresis is basically stool holding, and so that often results from painful constipation. So the child maybe has been constipated, had pain passing the stool, maybe required an enema, and so then is afraid to go to the bathroom and then holds the stools. Then we also have GER versus GERD. So GER, gastroesophageal reflux, is simply passage of gastric contents into the esophagus. And in very young children, this is a normal physiologic process. It just happens. And it can even include regurgitation and vomiting, so kids who, quote, spit up a lot. But as I alluded to earlier, this vomiting typically peaks at about 4 months and then resolves by 10 to 12 months. And so this kind of reflux in children older than 12 months is not common, and typically is something where you want to refer to a gastroenterologist to find out whether there's a cause for that. And then GERD is really GER that results in multiple vomiting episodes, which then interferes with growth or that which causes pain. So the child who experiences low pH in the esophagus and doesn't want to eat, if they're nursing, they might arch back off the breast and come off screaming. If they're formula feeding, they might start kind of yelling or screaming or crying as soon as they take the formula. It might be the child who just continues to vomit large quantities, and that's called GERD. Now, typically though, because fluid contents, like if a child has been nursing or taking formula and they spit up, that fluid really is it distributes into a large area. And so the mother may perceive that the child has vomited an entire feeding, and that amount may really equate to something like a couple of tablespoons. So sometimes parents' perception of how much the child is spitting up is not quite accurate. So in 2009, NASPGHAN, which is the North American something Pediatric Gastroenterology, Hepatology, and Nutrition Society, I think, and then the European something Pediatric, etc., wrote some clinical practice guidelines on GER, and they basically described a few categories. So the uncomplicated GER infant is the one who's the happy spitter. So this was my niece. You couldn't trust her. If you put her up on your shoulder, she was going to spit up all over it, but she never lost weight. She gained weight well, and she didn't seem in the least unhappy about spitting up. The GER infant who has poor growth or who's irritable, the suggestion is that you could try an extensively hydrolyzed or an amino acid formula. So because amino acid formulas are more expensive, I'd recommend the extensively hydrolyzed first, but that would be, for example, Alimentum, Nutramigen, Alimentum, Nutramigen, or Progestamil, which are the extensively hydrolyzed. And if those weren't tolerated, you could try an amino acid formula, which would be Elecare, Neocate, Pure Amino, and now Nestle has a new one called Alpha Amino. You could also try elimination of cow's milk and egg from maternal diet. There have been some studies to suggest that children who have sort of GER might respond to that treatment. You could also try decreasing the volume of the feeding so that they're not taking in so much at one time, but then of course you have to increase frequency so that they get enough in over the course of a day. Thickening formula, as I mentioned before when we talked about Enfamil AR, the thickening of the formula does decrease the vomiting episodes, but it doesn't decrease the number of, if you do a pH probe, it doesn't decrease the number of times that you have low pH within the esophagus, which can actually cause the damage. If you have GER and you have failure to thrive, you would want to consider concentrating a formula, but you might try an extensively hydrolyzed concentrated formula. For children, it would be similar to treatment to adults. You would eliminate gastric stimulants, so caffeine, chocolate in large quantities, spicy foods, high-fat foods, CO2, so like sodas, anything, tea, anything that might have a stimulant that would cause the transient relaxation of that esophageal sphincter. And then lactose intolerance is simply decreased ability to metabolize and digest lactose. And like we said, it's caused by a shortage of lactase, which is produced within the cells which line the small intestine. And you can diagnose it with a breath hydrogen test. And so that means that carbohydrate that is malabsorbed, then instead of being absorbed and taken out of the lumen of the intestine, it stays within the lumen where it gets fermented by colonic bacteria, and that they then release hydrogen gas. So someone who is expiring hydrogen gas versus carbon dioxide is showing that they're malabsorbing. Primary lactase deficiency is about 70% of the world population under age 5. It's very uncommon in white children, but it affects about 20% of Hispanic, Asian, and Black children. But it affects more of those as they get older. Secondary lactase deficiency is really lining of the small intestine is destroyed, secondary to underlying disease. So if you have that described damage to the gut, as I talked about earlier, that might occur with inflammatory bowel disease, like Crohn's or ulcerative colitis, celiac disease, if you've had an intestinal resection, if you've had chemotherapy, if you've had radiation therapy to part of the body that's near the gut, or if you've had an infection, all of those can cause a secondary lactase deficiency. A developmental lactase deficiency, which is like that we just basically have low levels of lactase prior to gestational age 24, and we typically don't try to save children until they're 23 weeks, and they're deficient. They have low levels of lactase up to 34 weeks, which is why the preterm formulas are lower in lactose than the term formulas. And then congenital lactase deficiency is just this rare autosomal recessive disorder. Affects those primarily of Finnish descent, and it causes a severe diarrheal disease, and they really do have to avoid lactose extensively, more so than those with a simple primary lactase deficiency or a secondary. So diet treatment, you need to basically decrease consumption of dietary lactose. So in blinded trials, those self-identifying with lactose intolerance can tolerate, and this is true for adults, 12 grams of lactose by itself and up to 18 grams with other food. Children may be able to tolerate somewhat less, but they don't have to avoid all sources of lactose. So like butter, cheese, yogurt, which has lactose, but which the live bacteria that are in the yogurt actually, they contain lactase within the bacteria. And once that bacterial cell has been disrupted, that lactase can help to break down the lactose. Then inflammatory bowel disease is the next topic. So we're going to talk about ulcerative colitis and Crohn's. And so ulcerative colitis, you'll recall from chronic care, is confined to the colon, has a very low prevalence, only 28 per 100,000 U.S. children. And then Crohn's, which may, as we said, affect any portion of the GI tract, but it has a slightly higher prevalence at 43 per 100,000. And remember, the Crohn's can be more severe. It can involve a full thickness of the gut. It can cause scarring in strictures, which then may cause the need for surgical intervention. And then you also have the potential for symptoms outside the gut, such as arthralgias. And that's kind of similar to celiac, remember, where we might have gut symptoms, but we might also have some joint issues or other symptoms. Ulcerative colitis, 65% of patients with ulcerative colitis who are children present with weight loss at diagnosis, and they may have multiple macro and micronutrient losses. Because they're diarrhea in the stools, you lose magnesium, zinc, and potassium, and so you may have losses or deficiencies in those. In terms of nutrition, the lactose intolerance is not as common in ulcerative colitis as it is in Crohn's. But there is a very expensive blend of probiotics called VSL number 3, which if you ever work in pediatric GI, you'll be very familiar with, which studies have shown have improved remission of ulcerative colitis with that blend in kids. And then Crohn's disease, nutrition problems, about 30 to 40% of adolescents with Crohn's have deficits in their nutrition status, in terms of maybe nutrient deficiencies, but 85% of those diagnosed present with weight loss, and they often have a reduced lean mass. So in terms of nutrition assessment, if you look at the studies, their energy needs, though, aren't necessarily increased. So the Schofield equation with an activity factor has been determined to be the most accurate in Crohn's disease. And I think, if you go back a slide, I think the journal article cited on the ulcerative colitis slide might be the one that relates to that. I'm not sure. And then increased protein requirement is something, though, in Crohn's, because you have destruction of that lining of the gut, which then has to be rebuilt. Fat malabsorption and fat-soluble vitamin malabsorption are both more common in Crohn's, and so are certain vitamin and minerals, such as B12, folate, calcium, and iron, and so those may need to be replaced. So typical strategies is that you really customize the diet to what the patient feels they can tolerate, that if the patient feels they don't tolerate lactose, you avoid those. Some evolving strategies, in an article that I had you read is one on exclusive enteral nutrition. Now in this case they mean enteral not necessarily to mean tube feeding, it means a combination of tube feeding and oral feeding, but all of it is an enteral product, in other words, no food. And some studies have shown at least equivalent remission compared to giving steroids in several for patients who take these. They don't know how it works. It seems to work. It's commonly used in Japan, a little bit more commonly used in Europe, slightly more common in Canada than in the US, but it is spreading. Some people feel maybe it works because there's a particular antigen, a protein that's present in the diet that isn't present in the formula, that somehow causes the gut to be able to recover from its inflammation. Maybe there's less production of inflammatory mediators because something that's in the diet is not causing the gut to be inflamed. Maybe it just is better at providing overall nutritional repletion because it's a balanced diet. When we eat ad lib. Maybe the teenager is eating chips and chicken strips and they're not getting a fully balanced diet, and so that enteral formula helps them to replete what they've lost. Maybe it's because those micronutrients, are all going to the gut, that there's nothing, it's maybe not having to be broken down as much before the micronutrients are released. Maybe it's altering the type and numbers of gut bacteria, and so that's changing the Crohn's. So we have shown through research that the EEN does reduce the bacterial biodiversity in the gut, which you might think of as being negative, but if it's certain species, because it increases particular species, maybe it's positive. It does seem to promote healing of the intestinal mucosa, and the polymeric formulas are just as effective as elemental. So some people are using partial versus exclusive, and some are using particular regimens to reintroduce foods, but it does promote normal growth and development, and it may actually reduce visceral fat. So going back on Crohn's disease, I mentioned people with Crohn's disease often have reduced lean mass, and they also have increased visceral fat mass, which we think is not good for their overall risk of chronic illness later on. Okay, so this is just an example of a case that you could do. It gives you a couple of drugs that people with Crohn's disease are often on, the 5-ASA and Humira, both which are kind of inflammatory mediators, and then it shows you that this child has low weight at 27 kilograms at 10 years of age. You'll have to calculate her BMI. She also has low H&H and glucose, and so you could practice doing an intervention for her. And that is the end of our slideshow today. Thank you.